name is Dr. Matthew Pianco. I'm a clinical associate professor of internal medicine at the University of Michigan in Ann Arbor at the Rogel Cancer Center, and it's my pleasure to present to you results of the MagnetisMM-9 trial, which was a trial looking at the efficacy and safety of step-up priming doses and longer dosing intervals of elranatamab in patients with relapsed or refractory multiple myeloma. Elranatamab is a BCMA CD3 bispecific monoclonal antibody, which is currently approved as a monotherapy for the treatment of adult patients with relapsed refractory myeloma who received at least 3 prior treatments, including an immunomodulatory drug, a proteasome inhibitor, and an anti-CD38 monoclonal antibody, and who experienced disease progression during the last therapy. Elranatamab was approved based on the phase 2 registrational MagnetisMM-3 trial, in which subcutaneous elranatamab was given as a 2-step-up priming dose schedule on days 1 and 4 of cycle 1 using 12 and 32 milligrams respectively, followed by a 76 milligram weekly dose in relapsed myeloma patients who had not received BCMA-directed treatment previously. In this trial, approximately 56.3% of patients had cytokine release syndrome. Approximately 14.3% of these were grade 2, and there were no grade 3 or higher events of cytokine release syndrome. It was noted that most of these events occurred after doses 1 and 44%, and after the second dose, approximately 20.2% of patients had CRS, and at the third dose, 5.9%. Recurrent CRS, also known as an event in which a patient had more than one event, occurred in approximately 15.1% of patients. In the MagnetisMM-3 trial, at a median follow-up of 28.4 months, the overall response rate was 61%, and approximately 37.4% had a complete response or better. The median duration of response, progression-free survival, and overall survival were not reached at 17.2 months and 24.6 months, respectively. The purpose of this trial was to report updated safety and efficacy results from the MagnetisMM-9 study. Now, to the design of this study, it was a phase 1 and phase 2 open-label, non-randomized trial of elranatamab examining an alternative 2-dose step-up priming regimen. So instead of the 12 and 32 milligram doses on day 1 and 4, in this trial, they utilized 4 milligrams for dose number 1 and 20 milligrams on dose number 2. So these were lower step-up doses. Eligible patients had relapsed myeloma and were refractory to at least 1 proteasome inhibitor, 1 immunomodulatory drug, and 1 anti-CD38 monoclonal antibody. So this trial effectively looked at an alternative step-up dosing strategy, and then also looked at different doses of elranatamab for prolonged treatment. So there are several parts of this trial. So they looked both at a full dose of 76 milligrams in part 2, as well as longer dosing intervals. And so in part 2A, 116 milligrams every 2 weeks. In dose level 1, in dose level 2, they evaluated 152 milligrams every 2 weeks. And in part 2B, it also had felt to explore further dose expansions, 152 milligrams every 2 weeks. And the recommended phase 2 dose, which was chosen to be the 152 milligram dose, was evaluated in the dose expansion cohort. The primary endpoint for both parts was grade 2 or higher CRS rate during cycle 1. And they also looked at secondary endpoints such as adverse events, the pharmacokinetics of the drug, as well as efficacy outcomes. The data cutoff date was August 19th, 2024, with a median duration of follow-up of 16.2 months for patients overall. A total of 85 patients were treated with elranatamab in this trial. The median age was 64 years. Most patients had triple-class refractory disease and were refractory to their last line of therapy. 18.8% of patients had received prior BCMA-targeted therapy in this trial. As for safety, the most common treatment-emergent adverse events overall included infections, which occurred in approximately 72.9% of patients. Of these, 45.9% were serious infections and were grade 3 or 4. Cytokine release syndrome occurred in 63.5% of patients and was mostly grade 1 or grade 2. The immune effector cell-associated neurotoxicity syndrome, ICANS, was reported in 4.7% of patients overall. There were no grade 3 or higher events of ICANS that occurred in this trial. Overall, 16 patients had a grade 5 treatment emergent adverse event, including 9 deaths due to disease progression, 4 from infection, and 1 each due to fall, subdural hematoma, and food poisoning. The primary endpoint of grade 2 or greater CRS during cycle 1 was 14.1% for patients overall. The time to onset and resolution was 2 days each for patients overall. The median treatment durations in the various parts of this trial were 8.6 months for patients receiving 76 milligrams in part 1, 2.9 months for patients receiving 116 milligrams every 2 weeks in part 2A dose level 1, 1.4 months for patients receiving 152 milligrams every 2 weeks in part 2A dose level 2, and 3.8 months for patients treated with 152 milligrams every 2 weeks in part 2B overall, respectively. Again, this trial is ongoing. The overall response rate for patients in this trial was 57.6% for patients overall. In the 76 milligram weekly cohort, the overall response rate was 66.7%. It was 58.3% in the 162 milligram every 2 week cohort, 36.4% in the 152 milligram every 2 week cohort, the dose level 2. This is the dose escalation. In part 2B, the overall response rate was 55.2%, with the dose being 152 milligrams every 2 weeks. The study found that overall response rates tended to be lower in patients with ISS stage 3 disease, which was 33.3% versus 64.1% in patients with ISS stage 1 or 2 disease. It was found to be had an overall response rate that was lower in patients who had extramedullary disease at baseline, 35% in that group, versus 64.6% in patients without extramedullary disease. Overall response rate was lower in patients with high-risk cytogenetics. It was 51.9% versus 61.4% in those with standard risk cytogenetics. And it also had a lower response rate in those with prior BCMA therapy, 50% versus 59.4% in people without prior BCMA-directed therapy. Among the 19 patients who achieved a complete response or better and were evaluable for MRD, or minimal residual disease, 78.9% were MRD negative. As of the data cutoff date, 10 patients overall switched to receiving 152 milligrams once every 8 weeks and had at least 3 months of possible follow-up. Among these patients, 7 maintained and 1 improved their response. Response was lost in 2 patients. With a median follow-up of 29.4 months, the data from the patients treated with 76 milligram every week in part 1 are the most mature data of all the cohorts in MagnetisMM-9. The median duration of response for patients in part 1 was 29.1 months, and the median progression-free survival was 17.1 months. In conclusion, the 4 and 20 milligram step-up priming regimen and alternative dosing schedules resulted in similar efficacy and safety versus the regimen used in the registrational MagnetisM-3 study, which used 12 and 32 milligrams. Responses were durable with encouraging progression-free survival and duration of response with the alternative step-up and longer dosing schedule. Although the overall rate was similar to that of MagnetisM-3, the CRS profile in this study was different. There were more CRS events after each subsequent dose, and there was a higher prevalence of recurrent CRS in MagnetisM-9 when compared with the registrational MagnetisM-3 study. These results support that the optimal elranatamab step-up regimen remains the 12 and 32 milligram step-up doses from the original regimen in the MagnetisM-3 trial. The preliminary results also suggest that reducing the dose frequency of elranatamab to Q4 weeks or Q8 weeks may not necessarily compromise efficacy. Future analyses of ongoing studies will be used to confirm these results. My other take-home in terms of what this trial means for patients is that the bispecific antibodies are an encouraging group of therapies that many of which have similar response characteristics and all of which have some cytokine release syndrome as concerns. We're learning more about how to optimally set up patients to start these drugs and experience minimal and predictable cytokine release syndrome. This trial supports the original dosing regimen of elranatamab, which included 12 and 32 milligrams, as that had lower rates of CRS and was more predictably able to result in CRS earlier, which is a more patient-friendly pattern of CRS. We'll continue to learn more about how to optimally dose bispecifics in the long term, such as using longer dosing regimens, potentially even finite therapy in the future. Results such as these included in MagnetisMM-9 support the effort in the future to optimize bispecific therapy using elranatamab for patients with relapsed and refractory multiple myeloma. Thank you.